who is our Amelia Aesthetics Raleigh surgeon on all things plastic surgery. So inside the community in Bustmob and on Instagram, we asked if you guys had any questions, and we have a good few to get us rolling. But as you guys pop on and you have questions live, put them in the comments and we'll make sure to address those as well. There's Dr. Hunter. Come on in. Got a text message. Hello.
Hello. Hello.
Oh,
Happy
you're
Halloween.
in the studio today.
I am trying to make it more professional. We'll see how this goes.
Well, I'm working from home today. My daughter is right over there. So if you hear a hand going into a chip bag, it's not me, it's her.
Perfect. See if you can share.
What are you eating? Oh, veggie straws. I should know this, right? Okay. Anywho, I have a bunch of questions that ladies have submitted. It's kind of all over the place, but we'll just jump in.
Perfect. I like it.
So first question, what is your favorite surgery to do and why?
An interesting question, but I'd say my favorite surgery is probably breast augmentation. I like breast surgeries in general. That actually is probably what got me interested in plastic surgery and actually, it's actually probably what got me interested in plastic surgery. She's helping me with my life here. Actually got me interested in plastic surgery, and I like the fact that you can have the pretty immediate improvement. Like I like the immediate change, and so whether it be breast augmentation, whether it be breast reduction, lifts, like those are things that I think I have been significantly interested in, and so that's my favorite. Although I like them all, but that's probably my favorite throughout.
Okay, it's my favorite too. And I'm not a surgeon.
Perfect. There it is. Hence Bustmob, right?
That's right. If someone is borderline needing a lift, how would they know whether or not to go with the lift or without the lift? I see this a lot inside of Bustmob. Now they've been proposed two options.
I think that it's because that actually is really hard and it's a really nuanced thing. And it actually is something that I still try to struggle with patients as we kind of work through it, because there's no right answer, right? I think it depends on two things, right? If you are one of those individuals, what you really want is a really high, a really round breast, you're looking for a lot of upper pole fullness, then in those situations, what you probably want is a lift, right? Like we get a lot of times when people come in and they don't say, like nobody comes in and usually it's like, I want a lift. Please give me the extra scars. Please do all of this stuff, right? They're just like, I want my breast to be really high. I want a lot of upper pole fullness. And the breast that you're kind of looking at after breastfeeding, weight loss, et cetera, is low. And so in those individuals, it's like you need a lift, right? It becomes pretty clear. But some women actually like a more natural, a more teardrop kind of bottom heavy aspect of the breast. And then those individuals, if it's still the nipple is in a borderline position, then they can usually sometimes just get away with just an augment and not necessarily have to have anything else. And so it really just depends on what the patient's goals are, which, you know, is hard. But like, that's where I think the goal photos mean a lot, and really just having a conversation. And when people are borderline, I actually think that while we try to do a lot of things in one stage, because who wants two operations when you can have one? Right? Like those are actually times where I'll have a real heart-to-heart with them and say, you know, I know we probably want to do this in one, but if you really are, say, hesitant of the scars, or you really, you know, aren't sure which way you want to go, it's not wrong to do the lift or to do an augment first. See how much volume you get, see what happens with the nipple. And then if it's not enough upper pole fullness, or you want the breast just tighter and rounder, then we can come back at a later time and do a lift. And so for those situations, after that conversation, usually that kind of helps put people at ease. And a lot of times people are then just happy with just the augment. It just kind of depends really on what it is that they want out of it, honestly.
Would you say that the Vectra 3D imaging kind of helps women in that process too?
I do. I think Vectra is actually pretty helpful because it helps too with the sizing. I think is a big thing, and then the ability to see like what happens with the nipple, right? Like the ability to use the Vectra and simulate with the lift and watch the nipple kind of elevate a bit, and then do the augment. I think I found it very helpful. It's funny. I think Vectra is one of those things. Vectra either really helps people, or I hear people on the other end it's like it was not helpful at all, right? Because sometimes the shape is a little bit different. Just depends on your starting position. But I agree with you for sure. I think Vectra is helpful for a lot of people in that situation.
Cool. Next question, mammograms. So when are mammograms required prior to surgery, and does everyone need them?
So in general, everyone does not need a mammogram. So I'll start with that. In terms of when is it needed, anytime I'm doing a breast surgery, if the woman is over 40 years old, I will use I think you should get a mammogram. And it's twofold. One is just a screen to make sure we don't have any problems, any lesions or any concerns for any cancer or anything like that up front, right? And then two is to make sure that we like them within, say, the past year, to make sure that we don't disturb your annual screening, right? Like if you're supposed to get a mammogram, say 1 week after I do a breast reduction, you're not going to be interested in doing that. It's not going to feel good, right? So you'd like to get the mammogram beforehand, because we wait about 6 months after surgery before I get you back on it. And the yearly screening is important, right? That's why there are yearly recommendations. So that would be what I say. Any breast surgery in a woman after 40, or for people who are younger, if you have a family history of breast cancer.
I hear this in Bustmob too. Is there a risk of the implant rupturing with the mammogram, since it's kind of squashing things down?
I would say, so again, it's one of those things, you never say never, right? But in general, no. That general, they do these extra views called Eklund views, because the idea is that you pull the breast tissue off of the implant to be able to do the mammogram. So the idea is that they're not squeezing the implant itself, but there's some pressure. They're trying to squeeze the breast tissue off of the implant, just like they would be squeezing it off of the chest wall. I know it doesn't sound very good, but it's very useful, ladies. It is very useful in terms of the screening process. But yeah, that's the idea.
All right. Well, I'm not 40 yet, so thank God. Are there any different recovery guidelines for women who get over the muscle as opposed to going under?
So no is my short answer for it. So everybody, I'm going to give you 6 weeks. And I think everyone here, you're going to get 6 weeks no heavy lifting, and that's to allow the sutures to heal. That's to allow just general healing after the process, right? Because there's always this race between how fast your body heals versus how fast these sutures start to dissolve, right? And so that's how you kind of come up with this 6 week guideline. But then what happens, what I tell people, is that at that 6 week mark, the difference between over the muscle and under muscle is rate of recovery, right? You're all going to end up, if you start here, you're all going to end up at the same place. But what happens is that if it's over the muscle, they do go back a little bit faster, right? The recovery is a bit more like that because, I haven't damaged the muscle and the movement is the same. But when it's under, it's a little bit slower to start, but you get back to the same place, right? And so if you need to get back to bench press tomorrow, then maybe in that situation, then over lets you go faster, right? But you will still be able to get back to bench press with under. So if that makes sense, that's kind of how I tend to explain it.
Because I think a lot of women think, well, I didn't go under the muscle, so I can work out sooner, like chest presses and stuff, but not the case.
Not the case. Nope. You may go back to your max a little bit faster, but you're going to work out. Both of you, if I do it over the muscle and under muscle on the same day, you both will be released to exercise at the exact same time.
Got it. That's good to know.
Gina, let me ask you a quick question. Is my light better for this one? The ladies came in to help me. Does that work, or do I need to turn the big light on?
I like the light. It looks good. Right. I see a little glare in your glasses, but that's wearing glasses.
That's the twinkle in my eyes. That's perfect.
There you go. See, I have a glare. That's why I took mine off. Actually, I have all the lights turned off too. That's just from the window. No. Okay. Back to question number 4. Leading up to a breast dog, I feel like we have a lot of breast dog questions. All right, leading up to surgery for a breast dog, do you suggest not working out your chest muscles for a certain amount of time before surgery?
No. So I actually have a lot of patients who, when I tell them that they're gonna then get 6 weeks off, people like to then focus on the on the chest before that, which makes a lot of sense, right? If I'm telling you you're not gonna be able to do it, they're like, I'm gonna get it in. I have no problem with that. Like, I think a couple weeks before of you either doing intense chest works out or you not doing a chest workout, it's not really going to change the thickness of your pec, right? Like if you're somebody who has thick pecs because you've done a lot of chest stuff or just genetically, that's going to be the same regardless. And so I think you should just stick with your normal workout routine, do the things you enjoy. And if you wanted to hit chest because, again, somebody's about to tell you can't do it, I have no problems with you doing that.
Got it. Yeah, you don't have to worry about that with me, though. I always skip that workout.
You're skipping chest day?
Always. I'm like, I'm so nervous anyways about it. I'm like, why even bother? I'll just do some cardio. Maybe that'll help.
Just do something else, balance it out.
Yeah, like that made any sense at all. Okay, so if you have 20 to 30 pounds to lose before surgery, like a tummy tuck, is it okay for them to still have the procedure, or would you rather someone be within a certain weight range before having surgery?
So I think that if you are, because I have this conversation with patients regularly for tummy tucks, right? If you are, I use the term, if you're hell bent on getting 20 to 30 pounds off, right? Like you are for sure, I'm losing 30 pounds, doesn't matter what I have to do, like they're coming off. For those people, I say then you should lose the weight and then come back, right? Because a 30-pound weight loss after surgery is going to change your results a little bit, right? Like your skin, you may feel like you have a little bit more loose skin, and it just won't be as tight as you wanted it. For people who that's kind of a general idea, they're like, I may lose it, I may not. I say losing some weight beforehand, right? Maybe half or so is probably useful. And then after the surgery, for some people, that's an additional benefit, another additional, motivating factor to say lose another 10 pounds or so. And for those people, I think that you can actually even look a little bit better if you lose a couple pounds afterwards, right? Like usually the amount that I can remove in liposuction, if you can do that with weight loss, right, it will only kind of further tighten you. And so for those situations, I think it's okay. So about 10 pounds in general, with 10 plus or minus 10 pounds is probably pretty reasonable. Beyond that, I do think you should do, you should try to lose that weight pre-op. And so another game plan, so we would say, let's imagine it's 20 pounds, right, that you want to lose. If you can lose 10 pounds before surgery and then maybe 10 pounds after, that's a pretty good game plan without feeling like you have to lose everything beforehand. Yeah. Because for some people, it may just not be realistic, right? So that's also an option and a thing you have to think about.
We got a question submitted down here. Don't want to miss that. Shelly King said, are we allowed to ask tummy tuck muscle repair questions? Yes, you are. Ask all the tummy tuck questions. I actually think I have one right here.
Ask away.
So what causes post-op swelling after a tummy tuck, and why does it take so long to subside?
So swelling is really just your body's way of dealing with trauma, right? Any kind of trauma, right? I mean, if you boil it down to basic things, right? You sprain your ankle, you get swelling, right? Like, I mean, it's just kind of, that's your body's response. And so with a tummy tuck, it's a big surgery, right? Like that's the incision, you have the muscle repair, and then for us, you have a significant amount of liposuction that we do with it. And so that's a lot of trauma, and it's a lot of healing, really, that your body then has to do. And why does it take so long? It's just because you have these little small lymphatics that actually are trying to drain a huge area, and it just takes a while, right? And if you imagine it, like when you sprain your ankle, right, or you hurt your hand, right? Everybody tells you to elevate it, right? You go home, you put it up on pillows, you hang it over your head if it's a hand injury. You can't really hang your abdomen over your head, right? Like
no.
So it's just kind of it's in the core, and so that is going to just be something that just takes a long time to resolve. And so I think the biggest thing, one, is just hand holding, and two, setting expectations that, look, you're going to swell, it's going to be swollen 9, 12 months, maybe a little bit longer. So we kind of just buckle in and we kind of just accept it. I think the garment helps a little bit with it, right? Sometimes lymphatic massage, but really it's just all those things that it's normal, right? And I just keep reassuring people it's normal. You haven't done anything wrong. It just takes a while. It's annoying, but it's just like your body doing its thing. I wish I could make it go faster. So
what's the idea behind the compression garment? Like, why should somebody wear that the first 6 weeks?
I like the compression garment because it just basically decreases the size of the container, right? Like, I mean, if you think about it from that, so it's external pressure to kind of push all of your skin in to kind of keep these compartments tight, right? So if you could imagine, right, if I had liposuction, like you have your muscle and then you have some fat in between and you have your skin, right? If I liposuction all this stuff, it's just a big space, and your body likes to fill space with fluid. That's swelling. But if I take a garment and I squeeze that space down, right, there's less space for your body to be able to accumulate fluid. So that's the theory with a garment, and kind of like why a garment helps, particularly in the beginning. Helps a little bit after that, but particularly in the beginning when things are trying to heal, that's what the utility of it.
Got it. We got another question. All right, Shelly King says, after a tummy tuck and muscle repair, what exercises can you do to keep your tummy tight? And when can you start doing exercises?
So for me and us here, so I say at about 6 weeks, I kind of, again, release you to do whatever it is that you want to do. So that's core stuff, that's Russian twist, that's crunches, that's just general running, whatever you want to do. Again, almost like the going back to the over versus under kind of discussion that we had, it's going to feel weird when you start doing core stuff and you've had your muscles repaired, right? They're not used to being side by side and kind of overlapped, and it's sore and it's weird. So I tell people, ease into it, but you can start doing core stuff. And I do encourage you to gently start doing some core stuff. And that is what will help you to kind of tighten your abdomen, because it's those muscles, just like before you had diastasis, right? The more you would work your abdomen, the tighter your core gets. And so your abdomen, your back, your obliques and sides, all those things together will help to tighten your abdomen.
I think we got one more question submitted. Okay. Yep. Okay. How long should we wear Spanx? I'm still 4.5 months later, 24/7. When can I take it off?
So for us, we, again, here after 6 weeks, I tell people that if they hate it, they can come out of the Spanx. If they hate it, right? And that is a certain significant portion of people. There are also a lot of people who start to kind of almost become a little bit dependent, right, on the garment, right? It's like a security blanket, right? Like they do not want to let it go. And for those individuals, it just needs to fit well, because I have also seen where people have had garments on that don't fit well, and it creates abnormal ridges, and they get these permanent lines, right, that are within their abdomen because the garment has been too tight. And so you're trying to use a garment or Spanx or whatever to hold things in, but if it's not smooth and it holds it in with these seams or kind of abnormal folds, it can make them permanent, and nobody wants that. So that's why we have this balance between saying you can come out at 6 weeks versus you have to stay, because I think a poor fitting garment is worse than no garment at all.
Oh, that's good to know. Just dropped something. That's really good to know. Because I always thought, like, I've never had a tummy tuck, but I would imagine it would feel comforting, the compression portion, and then it'd be hard to like take it off eventually, because you're just like you said, it's a security blanket.
Yeah, and it feels good. Like you said, like when you have it tight, it's almost like it's like swaddling a baby, right? Like they love that feeling tight and kind of wrapped up. And so it makes a ton of sense to me. You feel like your muscles are supported. At some point you have to get off, but I don't like to rip it away, right? If it fits well, I just gently say you need to kind of start to come off. We need to kind of start getting off of it. But some people really love it. So
all right, let's go back to breast. What keeps my implants? This is an interesting question. What keeps my implants from migrating through the body if I go over the muscle? How do they stay in place? So how does it not just like fall to your belly button?
I have to be honest, this is the first time I've gotten this question. There's some questions that you kind of get some repeats. And I actually think this question actually shows a lot of thought. I actually think it's a great question. So one, when you hear us and you hear other kind of surgeons talk about the importance of the inframammary fold, when people talk about bottoming out and you talk about displacement, these are the things that we're talking about, right? And so the fold is what keeps it at the bottom, like the shelf, right? It's the thing that stops the implant, right? Like it's supposed to hit against this and then not move because it's tough and tight tissue. And so that's under the muscle or over the muscle. And then when it's over the muscle, right, when people start talking about symastia and why it's important to not, everybody wants cleavage, right? But it's important to not try to over push that, because you have these strong attachments of your skin and fascia to your sternum, right? That stops it from going too far in the middle. And if you break that down, then that's really, really hard to fix. So that's another point of stopping it. You have strong attachments to your clavicles at the top, right? At the top of the breast. And the breast has stopping points, right? Like if you know, when you try to move it around, like it stops at the top, stops in the center, bottom, and on the side, the same thing. You have these strong kind of fascial attachments of fascia and skin to the underlying kind of fascia of either the ribs or the muscle that's over the ribs. And so those are the things that kind of make this kind of circle component of the breast to kind of try to limit it. So it's important that you don't damage those, because if you do, either with surgeries or from the implant itself and weight, et cetera, then that's where you start to get the medial displacement, lateral displacement, right? Inferior. You never really get it up, but it's the same thing. Those are attachments around. So actually, that's a really good question. It's one that honestly, no matter how long I've done it, I haven't gotten that question once. So that's good.
Can high profile implants have the same projection as a moderate profile implant?
It can if they have different volumes, right? And so I do think, I should have looked that up. I do think that there actually is one implant that actually profile and mod that has basically, or high profile and mod that has basically the same dimensions. It's really, really close, maybe off by like 0.1 in each direction. But otherwise, um, the more narrow, hence moderate, or the more narrow that it would be, for the same volume, it has to be taller, higher profile. Mm-hmm. And the wider it is for the same volume, it has to be shorter, hence moderate profile. And so in theory, in order for you to have a high profile implant and a moderate profile implant that have the same projection, it has to have more volume in the moderate profile, if that makes sense.
Yes, I have an implant over here. On my bookshelf. So, left to right. The more narrow this is, the more projecting it's gonna go.
Perfect. And there's your high profile. That's it. Perfect. I love your prop.
Thanks. I got them everywhere. How are we doing on time? Okay, good. So this lady is 11 and a half weeks post-op. She said her right breast seems to move around a lot more freely than the other one. Is that a normal part of the healing process, or is her pocket maybe too big?
So with that, both of those things can be a little bit true, I think, and it's kind of a little bit of a cop-out answer, but I think it's a real assessment. So if you feel like your implant is still moving a lot at about 3 months, the thing that I would probably say I would put you in is just a tighter bra. Because it is possible that as you're starting to kind of develop that capsule, it's possible that that capsule could kind of tighten up just a little bit, because that is what movement is underneath. It is that the pocket has been either stretched by the implant or at the time of surgery or whatever. And it's okay. Over time, sometimes they can settle to a reasonable position. And so I would just say I'd probably put you into just a little bit of a tighter implant, give it a little bit, a tighter bra, give it a little bit more support, and then see what happens. If over time you get out to 6 months, you get out to a year, and it's still moving more than you want, then in that situation, I say then I'm probably talking about some sort of revision where you're trying to tighten the pocket laterally. If you need to, maybe release it medially. Those are kind of the things. But the first thing I would try at 3 months, because you're still pretty early, would be just to try the bra in the beginning, and then see whether or not I can kind of get things to potentially shrink down a little bit, because you're still actively healing. So
got it. And I have one more question, and then we'll be done. What are your thoughts on getting breast implants with something like an autoimmune disease like lupus?
All right. And this is you saw the side. Because I think it's a big thing, particularly as it gets like a lot of attention from things like the news with the whole kind of breast implant illness stuff and all that stuff that comes up. So the first thing that I have to say is really what we'll structure the entire conversation on is that there's been nothing that has proven that you can get lupus or any other autoimmune disease from an implant, right? From a silicone implant. So that has been proven. So we can kind of throw that out and kind of all work from there. Now, lupus or any of these other autoimmune diseases, like they all come with various gradations and stages, right? And so it can go anywhere with lupus from something that's like just a simple skin rash to all the way up to heart and lung issues, right? And so if you are someone who has lupus that has, say, just a skin rash and you're not taking any steroids and you kind of are just monitoring it, under the guidance also with whoever is managing it, right? Like rheumatologist, primary care, if they think that it's okay and you and I have discussed the risk and you're willing to move forward, I'd be willing to proceed with that. I think that that's reasonable. Lupus in and of itself is not a contraindication. However, if you have lupus and you are on steroids, you are on big dose, immunosuppressants because your lupus has organ involvement and it's pretty severe. In those situations, I'd say you're probably not a great candidate for like this elective surgery, because it increases not just the lupus, but it increases your risk for complications. Because when you're on steroids, you're at high risk for infections and wound healing issues, all those things, I would say that an elective surgery is probably not the best thing for you in that situation. So it depends. Really, is kind of the straightforward answer about how severe it is.
Got it. And since we just got a question that popped up, I'll ask that one too. Can you get implants with thyroid disorders and mast cell activation?
So you can with thyroid disorders. So I've done them in people who have been hypothyroid. I've done them in people who have had prior Graves and things like that. This becomes one of those things where if you're having like an active thyroid storm, then no, it's not a good idea for you to do that, right? But that's sometimes people have asked about what labs and things do I need? If you have a history of a thyroid disease, then I need to get your thyroid levels. And if your thyroid levels are normal, they haven't changed, right? You're not changing your dosing of your medication. Then in that situation, if you have stable disease, then I would be comfortable proceeding with the procedure. And two, it depends on like the type of procedure, right? Like if there's a little bit of a difference between a 1 hour breast augmentation versus, a mommy makeover is several hours, right? Type of thing. And so I would say that those things are fine. It just needs to be stable and it needs to be acknowledged up front and kind of managed.
Got it. All right. I believe we are good. Let me just make sure we answered. Okay, one more because we got 4 minutes.
More. Let's do it. I love it.
Shelly King coming in with another one. How do you get rid of keloid scars under the breast? She's been using the silicone gel strips. But I guess if you know you keloid, it's probably good to let your surgeon know in advance.
It is. And so that's one of those things. There's a couple of things that you can do with keloid. So one, steroid injection, right? If you have been doing the strips and you've been doing the gel, like massaging, and it hasn't necessarily resolved, then I would say I see your surgeon, and then that's the time to start talking about steroid injections. Sometimes a couple of steroid injections can, if nothing more, soften the keloid and kind of decrease some of the itching that sometimes is associated with it. If the keloid is bad enough, then the next thing sometimes I will talk about is doing a scar excision and then planning for steroid injections after. But the thing about that is you got the keloid from a prior surgery. And so the chances of you getting it again after this surgery are pretty high, right? And the steroids can kind of decrease that. There's also, sometimes you can do a scar excision and then follow that with radiation, right? That certainly is a possibility. Now, it's supposed to just be skin deep, so we'd have to talk about how that affects with the implants and things like that. But this type of radiation for keloids is a little bit different than like cancer radiation, right? So again, it's supposed to just be skin deep, but that is a newer type of way that some people are kind of managing some keloids. So depends on how bad it is, but those are some options. And I would start with the steroid injection being the most simple thing to do.
Got it. All right. Dr. Hunter, I know you have a patient coming in very soon. So thank you so much for doing this for Bustmob and answering their questions and donating your time in Bustmob answering questions. I just think it's so cool.
Oh, absolutely. I love it. I'm glad to be a part. Thank you, ladies, for joining. It was a pleasure. And I hope everybody has a happy and safe Halloween.
That's right. Happy Halloween. Bye.
Bye, Jenny. Bye, Bustmob.